Okay, so let's now talk about the causes of hypothyroidism and classifications. So the most common cause of hypothyroidism in general is primary hypothyroidism. And before I talk about different type of hypothyroidism, and just I remind you by the how the I'm sure you all are aware about it, how the thyroxine secreted. So we have the hypothalamus, which secretes thyrotropin releasing hormone, and this hormone stimulates the anterior pituitary to produce TSH, and the TSH will stimulate the thyroid to produce the thyroxines. And the thyroxines will have a negative feedback on the anterior pituitary and in the hypothalamus. If it is too much thyroxine, for example, the hypothalamus and the pituitary will be suppressed. And if the thyroxine is low, the hypothalamus and the pituitary will be stimulated to produce more TRH and TSH. And this is makes us to understand the different biochemical profile in each type of hypothyroidism. So the most common cause, as I said, the primary hypothyroidism. And in primary hypothyroidism, as the name says, primary, so in the thyroid itself. So the problem is the thyroid. And biochemically, like the thyroxine will be low and the TSH and TRH will be high as a negative feedback. So we also have another type is subclinical hypothyroidism. And because it's subclinical, it doesn't, the patient doesn't have any clinical symptoms, but they will only have a high TSH. Even the thyroxine like free T4 and T3 will be normal, but the TSH will be high. And they said this would be due to high sensitivity of TSH to minimal decrease in thyroid functions. So if the patient T4 or T3 dropped even to like minimal decrease and still within the normal range, the TSH will be elevated. So in subclinical hypothyroidism, the patient will have high TSH and normal T4 and T3 and asymptomatics. And therefore, we will only do regular monitoring and they don't require treatment. Another type of hypothyroidism is the central hypothyroidism, and we have two subtypes. We have the secondary hypothyroidism and tertiary hypothyroidism. So the secondary is due to reduced TSH secretion from the anterior pituitary, and the tertiary hypothyroidism due to reduced TRH secretion from the hypothalamus. And those are less common than primary hypothyroidism. And we also have the congenital causes of hypothyroidism. And this could be a problem due to the complete absence of thyroid gland development, which we call thyroid agenesis, or abnormal development of the thyroid glands, which we call thyroid dysgenesis. There could also be another causes of inherited biosynthetic defects, which is due to genetic mutations affecting the thyroid hormone productions. There is also some acquired causes can lead to hypothyroidism, such as chronic autoimmune thyroiditis. The most common cause of that is Hashimoto's thyroiditis, and iatrogenic causes such as thyroidectomy, radioiodine treatments, or medications, including antithyroid treatments. Also, it could be due to inflammatory thyroiditis or iodine imbalance, since the iodine play an important part in the thyroxine synthesis. Any deficiency in the iodine may lead to hypothyroidism. And again, talking about the central causes, it could be due to tumor affecting the pituitary or the hypothalamus, or radiotherapy, which radiation damages the pituitary or the hypothalamic tissues, and also could be due to vascular events such as infarctions or hemorrhage affecting the hypothalamus or the pituitary. So how we're going to differentiate between these subtypes, as I mentioned in the beginning. So primary hypothyroidisms, we will have low free T3 and free T4 levels, and this will stimulate the pituitary to produce high level of TSH. So in the primary hypothyroidism, we'll have high TSH with low free T4 and free T3. And free T3, it sometimes could be normal because T3 is sensitized not only in the thyroid, it could be sensitized in the kidney and liver. That's why it could be normal. There could be some compensations there. Subclinical hypothyroidisms, as we mentioned, will have only high TSH levels with normal T4 and T3 levels. And the central hypothyroidisms, everything will be low because the problems from the hypothalamus or from the pituitary. So the management, so we'll do like a thyroid function test, as we mentioned, especially TSH and free T4, and also antibody testing to look for autoimmune disease. And we can do also thyroid glands to see if there is any development problem like thyroid agenesis or dysgenesis. And the treatment will be levothyroxine replacement. Sometimes could be for lifelong if the disease is autoimmune or congenital. And the patient will require regular TSH assessment for optimal replacement. I think that's all about it. Thank you. And if you have any questions, please let me know.
Thank you, دكتورة أبها.
Welcome.
Doctor, about the differential, first one Shihan, and second one primary hypothyroidism, and what
So in our case,
Hashimoto we can put?
in
Yes.
our case, so it is clearly that from the history, like the patient has intraoperative hemorrhage, and she developed not only symptoms of hypothyroidism, but also symptoms of hypoadrenalism, which informs of postural dizziness and significant postural hypotension. So like will be our top differential will be ban hypopituitarism, and we will manage the patient according to this. And this is like we are not going to do anything, like we will start the treatment even without confirmatory test, because the patients obviously and clinically manifesting the symptoms of ban hypopituitarism, and on examination is being confirmed, and also from the massive hemorrhage she had intraoperatively. But like just to add extra differential, so will be postpartum hypothyroidism, which is very common after having a baby. She had a baby 3 months ago, and she had the symptoms of hypothyroidism. And if you want to add something else, you can do hypoadrenalism, like because the patient has a postural hypotension, you can put anemia because the patient is lactating and feeling dizzy and tired. But to be honest, like if you just put two differential, it will be more than enough for the examiners.
We can put Hashimoto?
Nope.
No.
She doesn't have family history, and this is something just happened after the labor. It's very clear from the history. If she doesn't mention about this intraoperative hemorrhage, I may put anything else, but I may put all these causes I explained now for you, like causes of hypothyroidism. But yeah, I don't think we need to include it. Just be more precise. The examiner will be happy with you.
Oh, okay, thank you.
Okay. Any other questions?